Welcome to Casualty Live with me, Dr. Jean Wanjema. This is a show where every conversation is a step towards smarter decision making in the moments that matter. Together, we seek to learn, respond, and ultimately save lives. Hi, everybody. Welcome to episode 5, A Shocking Encounter. Today, like the title says, we're going to talk about shock. Did you know that shock doesn't begin with low blood pressure? If your patient comes in and they're already hypotensive, you're already trying to play a game of catch up. Your patient is already in trouble. So today's shock, we're going to figure out what it is, what are the clinical signs we should be looking out for, and we want to talk about all the interventions that every emergency clinician should know. So thank you for joining us. So, as we get started, let's define what is shock. So first and foremost, shock is a life-threatening condition. Let me say that again. It's a life-threatening condition. So when you look at the nitty-gritties, for one reason or another, there's inadequate perfusion to the tissues and the cells. When this occurs, the cells are unable to get the nutrients they need, the oxygen, the glucose, all of that. And when they're unable to do this, they check into plan B, which is anaerobic respiration. So then you start getting a lot of lactic acid buildup. As the cells become more acidotic, they start to die. As the cells die, the tissues also die. The organ starts to have organ failure. Every second left untreated of this organ failure leads you closer and closer to death. So that's why we say shock is a life-threatening condition that usually starts with inadequate perfusion for one reason or another. So that's the basic definition that you should understand. For some reason, things are not getting to the cell. The things that it needs are not getting to the cell. So now that we know what shock is, the tissue hypoperfusion, we're going to talk about the different types and the causes of shock, okay? So the first one we're going to talk about, that is often the first one everybody thinks about, hypovolemic shock. So hypovolemic shock is exactly that, low volume. So something is happening that has caused us to lose our circulating volume. So our circulating volume can either be the blood or the other parts like the serum, the plasma, the electrolytes, and all of that, okay? So that in turn makes the hypovolemic shock be categorized into hemorrhagic versus non-hemorrhagic causes. So hemorrhagic causes are blood loss, often through trauma, can be an external like a laceration, or internal like intra-abdominal bleeds, intrathoracic, and all of that. We talked about this in our last episode, Trauma Fundamentals. So feel free to go over to our YouTube page and rewatch that episode if you didn't catch it. Okay? So that's your hypovolemic hemorrhagic. Non-hemorrhagic causes of hypovolemic shock: dehydration, maybe we're not taking enough, or excessive diarrhea, excessive vomiting, you're losing. Even things like heat stroke, you're losing a lot of volume. Things like burns, you don't have your protective layer, so you're just losing your volume to the atmosphere around you. So these are some of the causes of hypovolemic shock, quite common, and I think they're pretty easy to address, especially if you're able to pick it up, okay? Second type is cardiogenic shock. Also, this one, like the name suggests, the problem is with the heart, okay? So it's a cardiogenic etiology. So here, you have things like maybe the cells of the heart are dying or dysfunctional, so ischemia for one reason or another. So you can have like your heart attacks and even the residual side effects of heart attacks where it takes a while for it to heal or it doesn't heal appropriately. So heart attacks can cause pump failure. Another thing is a disorder of the rate. Maybe your heart is beating too fast or too slow, okay? Your tachyarrhythmias, bradyarrhythmias. And we're also thinking about things like the fibrillation, ventricular fibrillation, atrial fibrillation. So here your heart is not moving is not pumping in a significant coordinated way. So you're not able to actually the cardiac output will not be sufficient, okay? So that's important to remember when it comes to cardiogenic shock. So the third type, we have our obstructive shock. Obstructive shock, also like the name suggests, there's some form of obstruction, physical, mechanical obstruction to how the blood is flowing, often in and out of the heart, okay? So the examples here are your massive pulmonary embolism. There's something blocking the volume of blood from moving between the heart and the pulmonary vessels. Another thing is your tension pneumothorax. So the cavity is just being compressed. So you're not allowing venous return and even cardiac output. So you won't be perfusing. Another thing is your cardiac tamponade. So the heart is being constricted, so it's not able to generate adequate cardiac output. So that's your obstructive shock. There's an obstruction to the flow. Last but not least, the fourth type of shock, distributive shock. So distributive shock is exactly that, a disorder of distribution. So the pump is pumping okay, the volume is okay, but for some reason it's not being distributed adequately. So often it's a disorder of the pipes or the vessels, the vasculature. So for one reason or another, there's inappropriate vasodilation of your vessels, okay? When this happens, it can be due to things like sepsis, episode 3, or anaphylaxis, or it's a neurological cause, okay? So you have inappropriate vasodilation, so you have reduced systemic vascular resistance, your BP drops, your venous return drops, your cardiac output drops, and then you have inadequate perfusion to the cells and tissues that need it. So all of these 4 types end up with inadequate tissue perfusion, which causes cell death, organ death, and if not addressed, can cause fatality in your patients. So it's important to, in the back of your head, understand the different mechanisms that go on to cause shock, so that when you're approaching your patient, you're thinking about all of this, trying to see where do they fall. It could be one type, and sometimes you could actually have a mixed picture where you have a patient who has hypovolemia, but they also have an underlying cardiogenic issue, right? So it could be cardiogenic plus hypovolemic, or it could be distributive plus cardiogenic, or hypo. So it can be one or more, but it's important to understand the different types because the management approach is a bit different for all of them. So now, what does that look like clinically? Okay, so if you think about it, our bodies are very smart. There's always some form of compensatory mechanism that kicks in when there's a problem, okay? Like if you're having really bad diarrhea, you've lost a lot of volume, your heart rate will go up to try and compensate for the cardiac output so that you're still perfusing adequately. Now, these compensatory mechanisms are not infinite, okay? There's always a point at which, in Africa Mwisho, it gets to the end of compensation and it's not able to compensate further, okay? So even clinically, you'll be able to see this trajectory in most of your patients. So there are early signs of shock and late signs of shock. Unfortunately, what is emphasized often is the later signs of shock. But what we want you guys to learn is to recognize the earlier signs so that you can actually intervene early enough and save your patient. Because like we said, shock, it's a time game. You want to intervene as early as possible so that you can reverse the progression or stop the progression, okay? So what are some of the early signs? So early signs would be thinking about like I said, your tachycardia. So you've lost volume, so your body wants to compensate or maintain your cardiac output, so your heart rate goes up, okay? Sometimes also you'll notice there's a tachypnea. So when your body starts to, when it doesn't have the nutrients it needs and it switches to anaerobic metabolism, you'll have a lot of lactate being produced, you're acidotic. So your body starts to hyperventilate in order to blow off the CO2, okay? So as to try and maintain a balance. In some of your patients, they might actually start getting a bit restless or tell you that, oh, I'm feeling a bit off, like something is wrong. They won't be like GCS 14, 13. They won't be confused, but they will be a bit uneasy and agitated because they're physically telling there's something going on in my body that's wrong, okay? Another thing that you can possibly start to see a bit earlier on, your extremities start to become a bit cold, your heart rate, you're feeling, a bit, your peripheries are cold, your heart rate has gone up, but maybe you're not feeling like the peripheral is as strong as the more proximal ones. Your urine output, maybe it was at 1 ml per kg, starts to go down, 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 things like that. Those are some of the things that you're looking at. Your BP won't drop suddenly. What you'll start to see is your pulse pressure, the difference between your systolic and your diastolic, starts to reduce slowly. So if it was like 140 over 70, now it becomes 130 over 80, right? Starts to narrow your pulse pressure. Those are some of the earlier signs, okay? When unaddressed, when you don't intervene, these things continue to worsen, worsen, worsen. So now your patient starts becoming hypotensive, that's a late sign. Hypotension is a very late sign of shock. Your patient is already in trouble, okay? Your skin is cold and mottled, your cup refill way past the 2 seconds that it's supposed to be. Maybe they're not producing any urine now, and then now is when confusion starts to go, where they're very drowsy, they're confused, sometimes they even tip into coma. And then if you've been able to also trend your lactates, they keep going high, 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 and the metabolic acidosis is quite profound. So these are some of the early versus later signs. But the most important thing to remember is that hypotension that has been hammered into our head as a sign of shock is a late sign. So what we want you guys to be able to address and identify as the earlier signs. You start asking yourself, why is my patient tachycardic? Why is my patient tachypneic? Why is my patient's skin very cold and dry? Why is my patient agitated? Why is the pulse pressure narrowing? Those are earlier signs, as opposed to the later ones. Now let's talk management. How do we manage these patients who are in shock? Okay, because we don't want them to die, right? So management leans on a couple of principles. So first, resuscitation. Okay, you want to maintain your ABCDEs. Resuscitation is very important because you want them to be alive. Okay. Number 2 is identification and treatment of the cause of the shock. Okay. So here, this is, I think, even the most important pillar, because if you do not treat the cause, you'll still be in the same state that you're in, or they will die. So those are the 2 important pillars of management. And for you to be able to especially identify what the cause is, we lean very, very heavily on history and your physical exam. Okay. So in your history, if it's somebody who's been diarrheaing for like 3 days, or maybe suggestive of cholera, things like there's a cholera outbreak, so you're thinking it's a hypovolemic. If it's somebody who's been stung by multiple bees, they were clearing, actually, we've had a patient like that, they were clearing some trees and then they were stung by multiple bees and they come in and their BPs are dropping, you're thinking anaphylactic shock. If it's somebody who has had fevers, has had an infection of some sort, you're thinking septic shock, right? If it's somebody who was in an RTA, you're thinking hypovolemic shock. So your history is very important to help you navigate and try and figure out what could be happening with your patient and what the likely cause of the shock is, so that you can target your treatment appropriately. Treatment of shock is not just fluids. That's a misnomer, a myth, a thing that we've learned, but it's not just fluids. Because if your patient has a pulmonary embolism or a tension pneumothorax, fluids will not help them, okay? So trying to understand what is going on with the patient, what's the history, what's the clinical exam, how do I resuscitate, how do I treat the cause, is a management approach that we want you guys to start taking. And luckily, once you've deduced that from your bedside history and physical exam, you can go to the Casualty app and open the appropriate algorithm, and it'll tell you what you should do, especially when you don't know what to do. We have an anaphylaxis algorithm, we have a pulmonary embolism algorithm, we have an ACS, acute coronary syndrome or myocardial infarction algorithm. We have a trauma management pathway algorithm. We have a sepsis algorithm. So the tools are there for you to use them. You just need, the only step you really need to do is understand the clinical picture of your patient and contextualize it so that you can appropriately use the tools at your disposal to help them. Okay. Not every patient who is in shock or is hypoperfusing has a volume problem. Let's remember that. That's the most important thing I can tell you about management. The rest I will leave to our expert today. We have an exciting interview coming up on critical insights, so let's stay tuned. Welcome to Critical Insights on Casualty Live, where we sit down with leading experts to unpack the decisions that save lives. On today's segment of Critical Insights, we have the absolute honor and pleasure of being joined by Dr. Benjamin Washira. Dr. Washira is the founder and executive director of EMKF. EMKF is the powerhouse where Casualty app was developed. He is one of the pioneering emergency medicine physicians in the country, And he is one of the leading change makers in strengthening emergency healthcare systems around the country. This conversation was very insightful. He broke down the whole concept of shock into very simple to understand concepts, and I'm sure you guys will gain a lot. So listen keenly and enjoy. Hi, Benjamin.
Hi, how are you?
I'm good. Thank you for joining me today.
Thank you for having me. Yes.
I'm so excited to chat about our topic today.
Okay.
We're going to talk about shock.
Shocking.
A shocking encounter.
Shocking. Yes.
Okay, great. I know it's very common in the emergency department. And for the longest time, many people understand shock as just hypotension. Right?
Okay. So low blood pressure.
Yeah,
yes.
Low blood pressure. But that's not exactly correct.
Yes.
So from your understanding, how would you define shock?
I think it looks at what do your tissues need? Okay, your tissues need a bit of glucose and your tissues need oxygen and then to keep alive. Okay. So when your tissues are not able to get the oxygen and the glucose to keep them alive, then you're probably in shock.
Okay. All right. So yeah, you're not getting what you need. Okay.
Yes.
That's simple enough. So then can a patient have somewhat normal vitals and be in shock?
So you see, as I said, there is an issue of delivery of the glucose and oxygen. But there's also the utilization by the tissue.
Okay.
So the tissue may be, let's say, poisoned. And yes, the blood is coming with oxygen and glucose, but the tissue can't utilize because it's been poisoned by something. And your patient then is also in shock. So blood pressure is people love looking at blood pressures, but blood pressures mean exactly nothing. Like it's numbers off a cuff somewhere. The question is blood flowing to the tissues and is it flowing adequately and enough to keep the tissues alive? And are the tissues consuming the blood, the oxygen and the glucose from the blood adequately? So it doesn't matter what numbers you're looking at. You could easily have a BP of 140/90 and still be in shock. You could easily have a BP of 90/60 and be perfusing. So it's all about perfusion and adequate perfusion to your tissues and ensuring that your tissues are getting adequately resourced with oxygen and glucose. In simple terms, really.
Okay. All right. So there are two components, the supply and the functionality or uptake, right?
Yes.
Okay. So then that means that there are multiple factors that could affect either of these.
So if you look at exactly what you're looking at, so let's talk about supply, okay? So maybe there's not enough flow, okay? So that means not enough nutrients and oxygen are getting to the tissues, okay? So that's one. But maybe there could also be adequate flow, but the blood does not have the nutrients, does not have the oxygen. So in which case, yes, the blood is coming, but there's nothing for the tissues to use. But it also could be the blood is coming, it's fully nutrient, it has all the nutrients, but the cells in the tissues are unable to consume that the nutrients from the blood. Okay. So in which case, at the end of the day, this starts leading to cell death and of course, all the things that go with that, yes.
Okay. So since we need to be thinking about it from a physiological cellular tissue level, what does that translate to at the bedside? What are some of the clues we should be looking at to be like, oh, maybe this patient is in shock?
So I think maybe the words I'd use is this patient has evidence of poor perfusion. Okay. So let's move away from the big word shock. Okay. So does this patient have evidence of adequate perfusion? Okay. The easier ones could be the first organs being perfused, of course, your brain. So confusion, that could easily be a sign of poor perfusion, okay, to the brain. Cold, clammy skin, what you feel, the peripheries, they're just all nice and cold. So your capillary refill is slow, okay? I think more than 2 seconds or something. It's slow. So blood is actually not getting there. So there is poor perfusion for some reason. And it's not just because it's a cold day. You're not peeing. Someone has not passed urine for some time. that means, again, they're not perfusing. Someone's heart is failing. Okay, so they're going into heart failure. Shortness of breath, some crackles in the chest. Again, your heart, signs of poor perfusion to the heart. So it's looking for, does this patient, so it's not what's the blood pressure, it's does this patient have evidence of adequate perfusion? So that's clinical bedside ones. I mean, we always use MAP, okay? A MAP of 65 as our cutoff, and anything lower than that, then we will consider that you may be hypoperfusing, and we also need to look for other signs of hypoperfusion. But yeah, so normally our target would say, let's have a MAP of 65, but the numbers are not as important as the clinical aspect of the patient. And then, of course, there are biomarkers we can use, which have, they're good, but of course, they can be misinterpreted. So increasing lactate levels. So, and again, it's the increasing in the number versus maybe saying a static number. So I know in sepsis, we use a cutoff, is it 2 or something? So, but it's not just the 2, it's just saying, has it going to 3? Is it going to 4? Is it going to 5? Is it going to 6? It's that will give you an indication that this patient is not doing well. So BPs are good as numbers, but they tell you nothing about perfusion. Yes, which is the most important part.
Okay. So then shock is often a continuum, right? It doesn't boom, low mental status, boom, low BP. So take us through, what are the steps to get to that irreversible point?
It just depends on what is happening. Essentially, as I said, your tissues start dying. That's the main endpoint, is your tissues are not getting enough oxygen. They go into anaerobic metabolism, start producing lactate and other things. And eventually, in a long, prolonged amount of time, the tissue then just dies because it's not getting really the oxygenation and nutrients that it needs. So usually it will start, I mean, it depends which pathway you came from. Shock can be sudden. Shock can be slow and gradual. Things like sepsis, for example. But someone having a heart attack can easily just go into shock because the heart has just stopped pumping. And as you think about shock, is looking at what contributes to blood flow. Okay, so there is the issues of the pump. Okay, that's your heart. Okay, there's the issues of the pipes. That's what the pipes that transmit blood to your tissues. And there's the issue of the blood itself. Okay, and an acute, any sudden dysfunction of this, sudden dysfunction of your heart, you go into quickly shock because again, you're not perfusing. For some reason, your blood vessels get blocked suddenly. Okay, like take a pulmonary embolus, you quickly start moving into shock. You bleed acutely, trauma situations. Okay, so then the pump is working, the pipes are working, but there's just no water in the blood in this case. And then in which case you go shock. So shock can be gradual, but it can also be sudden, where there's an acute dysfunction of any of these 3 components of the system, circulation system.
Okay. So you've started talking about it, the plumbing analogy when it comes to shock and what's actually happening. Can you tell me a bit more and more in depth? What is the pump? What are the pipes? All this.
Yes. So we use the plumbing analogy because it is actually just plumbing. I mean, the thing is, you have blood. Okay, let's start with what everyone knows. There's blood flowing from your head to your toe. Okay. Now, blood is the water, or what you'd say in a plumbing analogy. Blood would be the water. Now, as we know, in any plumbing system, the water needs to use certain designated pipes. Okay. So we have pipes that go to the heart, pipes that leave the heart and go to the rest of the body. That's why your arteries and veins come in, or veins and arteries come in. And then your blood vessels. Then you have the pump itself. Okay, so that's your heart. Okay, so the heart continuously beats at certain rate to ensure a certain amount of blood moves through your body per minute. Okay, so that's the main thing, and that's what keeps you alive. Okay, so it keeps all your organs alive. Okay. Now, of course, if you look at this entire sequence, you can see where there may be a problem that will then lead to parts of your body not being alive. Okay, so if there is no blood, okay, then there is just, the heart is pumping nothing, and there's nothing in the blood vessels, and your tissues do not receive the nutrients required, they die. Okay. If your pipes are broken, okay, then again, blood is going anywhere but the tissues, okay? This is a trauma situation where you're bleeding out, okay? Then that means the water is leaving the body or the blood is leaving the body and your tissues are not getting the blood flow. Similarly, it could be blocked, okay? So your blood vessels are blocked, means your tissues are not receiving the nutrients required because, well, blood is blocked. Now, and then you could look at the heart itself, okay? So remember how the heart works. The heart is dependent on a certain amount of blood volume getting into it and then leaving, okay? So there are a lot of problems that could happen, okay? It could be the heart doesn't have enough strength to push blood forward, in which case you start going into things like heart failure. Okay? It could be the heart is going too fast, okay, where then it's not allowing enough time for blood to get in for it to push. So at some point, it's just pushing small aliquots of blood into the system. And again, that also could be a problem. Then it could also be too slow. Okay, because again, it has to beat in a certain rate to get enough blood even to your small big toe there. So if it's beating, okay, so blood will never make it there. Okay, then you have stagnation, shock, and all that. That's another thing also, because if there's blood not moving, then nutrients are not getting in, toxins are not leaving, and your tissues are dying. Okay, so that's the analogy we use, and it's the same analogy that when we're thinking about how your body also compensates for when you have a problem. Okay, so your body is designed in a way that, and your brain is core to this, and your heart, of course, because the number one organ that needs all this, because is your brain. Yes. So when there's no enough blood flow to the brain, there are body receptors that will try and figure out where is the problem and how do I maintain blood flow. Okay, so there's no situation at one point in life where, let's say your brain, let's use random numbers, your brain needs 2 liters of blood per minute, that your brain will function at 1 liter of blood per minute. That is not acceptable. Your brain is designed to keep you alive, okay? And so the rest of your body, at least parts of your body. Yes, we can kill kidneys off, we can kill the heart a bit off, but your brain is just purely designed to keep you alive. So the moment your brain is perceiving a situation where it's not getting enough blood flow, your body is designed to try and figure out, how do I do this, okay? So, and this is where the compensation things happen, okay? So, for example, if your blood volume is low for some reason, okay, then your body will trigger your heart. Your brain will trigger your heart to say, beat faster because I'm not getting enough blood and I need to stay alive. So beat faster so that the little blood that you have can keep me alive. But that can only be, that situation can only be maintained for such a long time. Similarly, and that's why you get your tachycardia, okay, to keep your brain alive, and your numbers may look fine, but it's your body trying to compensate. So it doesn't mean you don't have a problem, okay? You have a problem because you have a low blood volume. And no, that's the thing about volume, okay? And so you can lose blood volumes in, I'd say, 2 main ways. You can either get out, okay? So you're bleeding out, or, so your pipes are normally, let's say, this narrow, okay? Then all of a sudden your pipes become fat, okay? So the volume of blood that existed in the smaller narrow pipes now exists in bigger pipes. So that means you do not actually have enough volume inside the pipes. So in which case then your body starts perceiving, oops, we have lost volume. But it's essentially your pipes have expanded. Now the volume of blood that was used to pump through narrow pipes now is pumping through a bigger volume. And again, so then your body again starts compensating. How do we make this pipe smaller? How do we... And that's the other thing also. So sometimes even when you bleed out, for example, your body will start saying, I think I'm losing blood somewhere. Can I decrease the... Funga. Yes, let's reduce the pipes so that whatever blood is left is moving faster through the system. Yes, and that's why, and that's actually explains now, for example, when your patient is in shock, They have cold peripheries because between your brain and your fingers, I think your brain will take priority. So your body will start shutting blood supply to certain areas, okay, of the body to concentrate the blood centrally, and more importantly, to keep the blood within the brain system.
Okay. All right. Yeah, that makes a lot of sense. And also understanding that physiology also helps you when you're looking at your patient, right? Yeah. And you've alluded to the different kinds of shock. Let's talk more about that. How many types of shock do we have?
So there are I'd say 3, 4 kinds of shock, and they don't always exist in isolation. That's also the problem. So it's not, if you can only have one type of shock, you can have multiple types of shock. Okay? So the broad categories are, the one we commonly will talk about is hypovolemic shock. Okay, where you have low volume. And again, this is, you have to think, do I have low volume because I have been diarrheaing and vomiting for some time? I have been bleeding. So where is the blood? Where is the volume gone to? And sometimes it's not left your body, it's just gone. The pipes have become bigger. So now all of a sudden you have a bigger space to fill, and that's kind of hypovolemic shock. What we see is, for example, sepsis. Then you have cardiogenic shock, okay? And this is where your pump has a problem, okay? So your heart is either not pumping hard enough, it's not pumping at the adequate rate. So it's either pumping too slow or too fast, okay? Each of which can lead to cardiogenic type of shock. And then you have the obstructive shock, okay? This is where the pipes are blocked, okay? Now here's the tricky part. Pipes can be blocked from inside the pipe or from outside the pipe. So something like pulmonary embolism, where there's a clot inside one of your major vessels in your lungs, then causes a blockade, and then you end up in like obstructive kind of shock. But also, let's say sometimes you have tension pneumothorax, cardiac tamponade, where there is so much external pressure inside your lungs or around your heart that stops blood flow through your pipes. So your pipes are patent, but now they're being compressed and closed. Then you get a bit of obstructive shock. Okay. The other part of it is what we call cytotoxic shock, okay, which sometimes a lot of people ignore, and is where your tissues have been poisoned, things like cyanide poisoning and things like that, where then your tissues are not able to consume the oxygen and they're not able to metabolize the nutrients coming through the blood. And then you end up with a type of shock that, yes, there's good blood flow, but your tissues are actually just dying because of the toxicity.
Okay. How about distributive shock?
Distributive shock, I always consider it more of a hypovolemic type of shock. In the sense that it's, the main thing is your blood vessels have expanded. That's why I say when you're looking at patient is hypovolemic, okay, it's, did they lose blood? Did they, so is it that they're losing blood, or has the blood been redistributed? So yes, there is distributive shock, but distributive shock essentially translates to your blood volume comes down because your pipes are off, okay? So you've not lost volume, your pipes have just expanded, yes. So that's distributive shock, yes.
Okay, all right. In terms of hypovolemic, how do you tell this is a hemorrhagic or non-hemorrhagic?
History. At the end of the day, you have to speak to your patients. Okay?
If they can talk.
If they can't talk, then you have to figure out where is the volume. Yes, okay? And that's right. So, of course, if it's a trauma case, then you're trying to figure out, are they bleeding from somewhere, okay? You're doing your quick fasts, and then considering still, are they bleeding where I can't see? You see, because that also happens. It's not always that the blood is flowing out of the body. Sometimes it's your bleeding areas you can't see. And then, but with your history of trauma, suggestions of trauma is something to factor in. In your history, again, someone saying diarrhea, vomiting, and all that, then you can work out that potentially they have lost volume in terms of just the diarrhea, vomiting, and water. Okay. But someone, example, who has fevers is febrile. So they have lost volume because of expansion of the blood vessels and all that. But there's also insensible losses, sweating and all that. So there is a volume loss somewhere, yes. So but you have to take a history, you have to examine your patient. Clinical exam will give you 90% of your answers as to where exactly the issue is.
That's true. Okay. What I call distributive, we talk about the septic shock, like we talked about last month, anaphylactic, also neurogenic, right?
Yes.
Yeah.
Yes, because your blood vessels will expand. Yes.
Yeah,
Yes.
yeah.
And so you see, neurogenic can be a bit of both. You see,
Yeah.
there's blood vessel expansion,
Yeah,
but
yeah.
also your heart is not pumping enough.
That
yes.
is true. That is true. Also depending on the level.
Yes, that's what I'm saying. Think of shock into buckets. Can easily trip you into not understanding. Yes. So patients don't read the same textbooks we read. They come with their own versions of shock. And so it's thinking through the entire pathway to figure out what is actually happening at cellular level, at tissue level. Yes, to be able to diagnose and manage appropriately. Yes.
Okay. And then while we do work in the ED, we rarely have a lot of information, right? We have like small snippets here and there, but you can have maybe an elderly patient has been brought in, you're being told, yes, they've had multiple bouts of diarrhea, but they do have pre-existing conditions. Maybe they've had some form of heart failure or kidney failure. How do you differentiate what's actually going on the patient bedside in terms of where the problem might lie? And also, like you had alluded earlier, sometimes you can also have a mixed picture. So how do you approach this patient?
So the key thing is, first of all, is the patient perfusing? Okay? And are they compass? I mean, are they GCS 15? Okay? Can you talk to, are they alert? All right? Are they having a conversation with you? Okay? That's a good sign. At least some blood is making it through the brain.
Yeah.
Okay? Then the next part of it is to look at them in terms of, are they warm? Okay? Are there blood getting to tissues and all that? Simple things in the history. When did you pee last? Okay. Of course, if they have not have a problem peeing, that could be easily hard to determine that. But if someone was having normal urinary flow, then when did you pee last? So history, it all starts with history, and of course, gathering that history of what have they been going, vomiting, diarrhea. Of course, the first thing we'll always get to the AD is quickly pick your vital signs. Okay. And these ones can guide you in terms, but even just feeling a patient's pulse, by the way, that's a very good thing also. Can you actually feel a pulse? Yeah, radial pulse, for example, because you can't feel one. It's probably patient maybe superbly vasoconstricted or poorly perfused. What's your cap refill? Again, bedside clinical skills. Then now you can look at your numbers. And to be honest, for me, numbers are more or less the last thing I look at. Because because you see, like even BP on its own, the wrong calf size, the wrong patient size, everything can either lead you to overestimation or underestimation of the blood pressure.
True.
Many people get comfortable saying, oh, BP is fine. It's 110/70. But BP is 110/70, but patient's heart rate is 150.
Yeah.
Okay? So your body is fighting really hard to keep you alive. So the number 110/70 means your patient is actually probably, and heart rate 150 they're superbly in shock. It's the heart rate keeping up. So for those who like the mathematics of it, cardiac output is stroke volume times heart rate. Okay. So cardiac output is what I was talking about earlier, where your heart needs to release an amount of blood per minute. Okay. So and this cardiac output has to be maintained. So some days the heart is like, today let's just release like kidogo blood per minute. Then next week this has to be sustained. So if your cardiac output, I want to go to actual numbers, but if your cardiac output, let's say, is 10, okay, at no point will your body allow your cardiac output to become 2. Okay, it will always try to maintain 10. Okay, so let's look at now the simple mathematics. You said cardiac output is stroke volume times
vascular resistance.
Heart rate. Okay, so cardiac output is stroke volume times heart rate. Okay, so if let's say cardiac output is 10. Okay, and on a normal day, stroke volume is 5, heart rate is 2. So 5 times 2 is 10. Okay, But for some reason, you've lost blood, okay? So we can no longer have a stroke volume of 5. So now, let's say we've dropped it to 2, okay? Your heart rate has to go to 5 to maintain, yes, to maintain 10, okay? So if then your cardiac output is coming, and that means everything is going down, you're probably at the end of things. So the numbers, as fantastic as we always try, because you always hear people say, oh, BP is normal. There's nothing like a normal BP, by the way. It is, everyone has their own BP. Okay. The key thing is, are they perfusing? I think we need to move away from patient has a normal BP. No. Patient is perfusing. Well, that's it. Yes. Those numbers, it can be high, low, whatever, but are they perfusing? Okay. And then also look at, so I look at that number, but I think the number that I always look at keenly, always for me is the heart rate. I think in my years of practice, you must always, the heart rate is the most, I wouldn't say I don't adapt to check whether the sensitivity and all that, but why is my patient tachycardic? Okay. Why is my patient, of course, there are flaws because sometimes they could be on beta blockers, calcium channel blockers, so that you won't see that heart rate go up. But if you ever have a patient in front of you whose heart rate is above 100 or at least even the slow, yes, above 100 or above getting to 90, they're not in the 70s, 80s range, they keep going up. The question is why?
Something's going on.
Yes. So is it they're in pain, discomfort? Are they? So figure out why the heart rate is going up. Let's remember from our formula here, a heart rate going up could easily be an indication of many things. And one of the things is your body trying to compensate for a low cardiac output. Yes. And so that's the thing. And also, so back to, because those people love the BP. So your blood pressure formula is your cardiac output times systemic vascular resistance. So it is, the full formula would be, what you see as a blood pressure is your stroke volume, how much blood your heart is pumping out, your heart rate, how fast your heart is beating, and how compressed or uncompressed your blood vessels are. So back to the three components, okay? How the volume part of it, the pipes part of it, and your pump part of it, okay? So back to the analogy around
the plumbing.
The plumbing. So your blood pressure is a product of three different components: pump, pipe, and volume. Yes. Okay. And so if your blood pressure is coming down, which of these three components is being affected? Because X times Y times Z is what gets you the BP. So if your BP is coming down, or one of these numbers is off, okay, your heart rate has gone up, or your patient is cold, clammy, okay, the resistance has increased significantly, something is happening. Yes.
Okay, that makes a lot of sense. So let's talk about the patients. Let's talk more about the patients who don't meet that normal physiology of compensation, right?
When you say normal physiology, explain.
The way you're saying, my cardiac output is low, so my heart rate goes up.
So they're not compensating.
They're not compensating as we would expect, right?
And there are many reasons for that.
There are usually very, very many reasons for that. So how do you differentiate these people and be like, I know the heart rate looks normal, but there's a problem?
It's, you see, again, perfusion. It starts and ends with perfusion. So the question would be, what have you picked up? Okay, is it their confusion? And again, all these things can be confused for many reasons. Yes. So back to your clinical exam as you are taught in your third year or whatever year of medical school, is yes, blood pressure is normal. Heart rate seems normal, but this guy is just cold. His whatevers are not. In fact, a simple one, we were playing around last week, just some scenarios, is your patient, for example, is, you can see he's running a bit of a tachycardia, BP seems normal, but he's saturating at 85. Okay, so why? Why? He has no infection, whatever, so why? Why is, so, and is part of, there's not enough blood getting to the lungs for it to be oxygenated for them to pick up. So it's looking at the clinical picture and trying to figure out what is abnormal and what is, so are they not perfusing? Capri is slow. Are they drowsy? Okay, your neurological status. Again, if you are monitoring urine output, has the urine come down? And especially in areas, for example, in areas like critical care, remember when we were young, at some point, yes, very long time ago, like you'd be woken up in the night because, so you used to have 0.5 mLs per hour of urine output. Yes. The nurse would wake you up because the patient only produced 20 mLs of urine, for example, in the last 1 hour. And your BP, all vitals are fine. Yes. Fine. Yeah. But the question is, where is the urine?
Yeah.
Yes. You know, especially in critical care, that's why I love critical care in my other life, is where is the urine? And you'd have to troubleshoot where has the urine gone to. Yes. So it's the same way here. You're like, where exactly is the problem here? Is this patient has cold, clammy skin? Where is the problem? Or this patient is having low GCS and you think it's a perfusion issue. So where is the blood going to? Or is there even enough? Yes.
Okay. All right. So which subset of patients should we have a keener look at or higher index of suspicion?
I'd always work with extremes of age. Okay. Kids are fantastic at compensating.
Yeah, they are.
Yes. So a kid will be there, BPs are looking fine, they've considered themselves, heart is running up. That time they've lost almost 30% of their volume. True. So kids are them, in fact, and they have subtle signs, okay? The hyperventilation, the cold, clammy skin, the drowsiness, all those things. So pediatrics, shock will kill them faster than anything else. Yes. And so those are the groups of people where they look fine, but they're not fine. Okay. Yes. And you should always worry about kids as, are they perfusing everything? Yes. And then we have the elderly people. Okay, they're always on a cocktail of drugs. Some of those drugs could be impeding their compensation. And their physiology varies significantly. So an old person may be running heart rates of 110 or maybe actually heart rates of 90. That time they're in shock. Yes, their body is just not compensating adequately. Yes, so extremes of age, I think, is the key thing to look at. I think another special category, because we're now seeing a lot of mortality in these patients, is your septic patients and your trauma patients. Yes, trauma patients, because again, we expect you're seeing where the blood is going. So hidden bleeding or obstructive shocks, all those things easily can move a trauma patient from alive to dead quite quickly. Yes, so, and the other part of it is delays in our management, especially of trauma patients, where patient is, you can see they're going into shock and we're just giving water. I mean, when patients lose blood, they should be getting blood. So start blood transfusions early, give your tranexamic acid. So trauma patients, mortality is significantly increased by our delays in the management, playing around with crystalloids and other fluids other than blood. Yes, so those would be our patients. Septic patients they're the ones also who will look normal to you. In fact, they're feeling nice and warm. You're like, couple, they're talking to you. But their blood, remember the issue with septic patients is a distributive shock. The blood vessels are the size of, I don't know how big they've gotten, but, and they're talking to you, they've not passed urine for some time. And then the next thing you're talking about is, they're running a tachy, which is keeping them, the tachy is what is making you think, these people are alive, until the heart can't. And that's the thing about tachycardia, is your heart can compensate until it can't.
To a certain point.
The point where it can't, imagine that's the end. So, as I said, heart rate, always look at the heart rate. Yes, of course, be worried about elderly people because the heart rates may not be as well. Kids will compensate easily, but the heart rate is, why is my heart moving too fast? Yes.
Okay. All right. And that also means that your early clues are the tachycardias, tachypnea.
Yes, exactly.
And what are the later ones?
The opposite of that.
The BP, the mental status.
The BP is probably one of those last. Like it's your mental status, better mental status is getting off, is you've really lost a lot of, you're not perfusing that brain at. By the time your patient's GCS is dropping, is blood is not making it to the brain. And this is the brain that was designed to self-protect. So that means you've potentially exceeded your compensatory mechanisms. And now you're actually now going into the, point where things are not working.
Yeah, that makes sense. And even in terms of like a triage perspective, these are the patients that you need to flag early, right? The ones who on the news like have like one score where it's just a tachycardia. You need to review them
the why earlier. It's why is your heart running too fast?
Because it's very easy to have somebody seated in your waiting area waiting to be seen,
and they look fine.
They look fine.
But they're running a heart rate of 120. And
next
they're not complaining of any pain. They're just sitting there with a heart rate of 120. You're like, huh? Okay. Yes.
All right.
And the thing about shock, and that's the thing that people need to understand, is you need to manage it early. Yes. I think having a patient in your department experiencing shock continuously, they came to hospital. So I think that's the thing I've seen a lot, is where we are slow to act, and you're like, let us just try this. Like, we're happy that they're not we've discovered they're not perfusing, which translates to, if you think about it, you're not perfusing, your tissues are not getting the nutrients, the tissues are dying. Okay. So your patient, as long as your patient is remaining hypoxic or hypovolemic or in poor perfusion, their tissues are dying slowly. Let me work with that. Yes. And unless you fix them quickly, this has implications in terms of even their morbidity and mortality. So you should not be comfortable sitting with a shock. You're like, let's give 2 seconds of this and see where it goes. You are the same way a patient's heart stops and we all respond immediately is the same energy that is required to respond to a patient who is not perfusing well until they're perfusing well. Yes, this is not one of those, let us give antibiotics and see how things happen. Let's wait and see how they will do. No.
We'll wait for labs.
Yes, exactly. This is where aggressive management of your physiology for shock, for hypoxia is really instrumental in improving your patient's outcomes and should be addressed in the same energy as cardiac arrest, for example.
Okay, all right. Let's talk more about management. Again, like we said, ED, patient is brought in, you have very scanty information, you have your clinical signs that are suggesting, this is shock, because shock is a clinical diagnosis, right? So you, as an emergency physician, what is your approach in the first 5 minutes to this undifferentiated patient? Take us through what you would do.
So if I've done my history and whatever.
You've done your history.
So first thing I need IV access.
Okay.
Now, people, you need to get IV access. IV or IO access. Another thing I've seen a lot is people struggle sometimes because the patient is too vasoconstricted. So they can't actually get IV access. And you've tried the bigger ones, whatever. You need immediate IV access. And if you can't get IV, get intraosseous access. Okay. It's easy in kids, a bit more complicated in adults, get intraosseous if you don't have the tools. But get access. Yes, because you will need to give something into these vessels, into these patients up. Okay, they're not gonna drink themselves out of shock. Yes, okay. You don't be drinking bottles of water here expecting that their shock will recover. No, something has to go into the vessels. Yes, okay. So you've done your ABCs, of course, because sometimes you may need to give a bit of oxygen if they're not perfusing well and getting enough oxygenation. So you've done that, and then the next thing you need to figure out at this point now is, where am I in this spectrum? Other things to factor in is, for example, if it's obstructive shock, then this will become in your ABCs where you've corrected that, your attention pneumothorax. If there's any consideration of cardiac tamponade, you scan that and reduce that. Because especially in conditions like pulmonary embolism and tamponade, starting aggressive fluid resuscitation may be detrimental to the patient. So do not always. So another thing, just something people need to understand. Hypotension is not hypovolemia. Okay. A low hypotension is not hypovolemia.
True.
A low blood pressure does not mean your patient doesn't have enough volume.
Yeah.
Okay. So the knee-jerk reaction we've seen a lot in healthcare practice where, patients BP low, let's give fluids.
Aggressive fluid resuscitation.
Who told you the patient did not have fluids? Yes. So it's, as I said, first thing is get IV access. I didn't say give fluid, I said get IV access, because you will need to figure out something, and whatever you're going to figure out, intervention will have to go through an IV access of some sort.
Yeah.
Okay, so the next thing is, where are we with this? Is it a volume problem? Okay, and then if it's a volume problem, because that's we normally start with the easy one, the volume problem. Assuming we've gone A, B, C, A and B is fine. Yes, it's a volume problem. Now, is it a volume problem because there's volume loss, or is it a volume problem because the pipes have gone up? Okay, and if there's if it's volume loss from water leaving, the question is, what left? Okay, is it blood that left the patient, or is it water, diarrhea, vomiting, and the rest? Okay, so if you have history of insensible losses, diarrhea, vomiting, whatever, then of course you can start off with your crystalloids. Remember, at this point your patient has poor perfusion, so we've established your patient has poor perfusion. Okay, so if you have a volume loss, then immediately definitely start replacing the volume, okay? If the patient was bleeding significantly and you're going to the point where you're poorly perfusing, let's start giving some blood, okay? If it's the water, let's give you water, okay? That's the initiation part of it, okay? Now, and then if it's your heart, again, your heart is either beating too fast, or too slow, or not beating at all. Okay, so that's the other part of it. It's slow, whatever. It's not pumping hard enough. Okay, in which case, then water may not be there. Remember, your patient has not lost volume. Okay, so your patient is not poorly perfused because there was a volume loss. Your patient is poorly perfused because the pump has a problem. So if the pump has a problem, they need to fix the pump. Okay, either slow it down, okay, or make it faster. Pick it up, okay? This is your tachycardia and bradycardia algorithms coming, or give it some energy, give it a drug to help it pump harder. Your inotropic support comes in, okay? Then the other part of it would be looking at, so we've said the volume, but as I said, your patient sometimes does just have one problem, okay? And sometimes you may not be, the volume may not be going in fast enough. And for example, septic patients where you have a combination of cytotoxic problems, you have a combination of vessel problem, you have a combination of volume, you actually also could have a cardiac issue from sepsis. So in these patients, for example, then you want to combine some therapies. So you want to, start some volume, but you also then want to consider, do I need to give some vasopressors to close up a bit, or some inotropic support to help the heart a bit. So this has to happen instantly. It's not, let's give volume for the next 6 hours, then we come back. No. Getting a patient to perfuse as soon as possible is a priority. So you're not leaving this patient's bedside. You're in this patient's bedside, looking at any improvements in the markers you are using that you use to determine that this patient is poorly perfused. Are they getting better? Are they getting warmer? Are they getting more conscious?
More alert,
yes. And blood markers and things like that, if you really want to use that. But key thing is, where are we at clinically? Yes.
Okay. So then how do you balance enough fluid versus too much?
So fluid is a tricky thing, okay? Because you could easily push your patient to the extremes where then you have too much fluid, okay? But I think a lot of it is looking at, again, put a catheter in.
Okay.
Yes. Put a catheter in early if that's what, because most in our settings, that's what we have to monitor. And then start monitoring your urine output, okay? The usual 0.5 mLs per kg for adults, and this is 1 for kids. Yes. So start monitoring your urine output and see, are they producing enough amount of urine? Because we just need you to perfuse at a baseline level. You don't need to overshoot you, okay? And I think and the other thing is, how are you monitoring your response. Of course, in your fancy settings, you may have all the tools and gadgets, your lactate and markers, and the lactate is nice to have. But if you don't have lactate, then let's work with urine. And you really, again, also factor in maybe does your patient have kidney failure? That's a different discussion. Yes.
Complicated.
Yes. It gets a bit complicated here. Okay. But I think the thing is, if you've given a patient, depends on your patient. I mean, as healthy adult person, you could easily get away with 1 liter or 2 liters of fluids.
Yeah.
You're elderly, please, and the higher the age, please, the less amount of fluids you want to be giving them. So 250 mLs, 500 mLs. So another thing is, again, do not give all the water and then come reassess, okay? It's give your first bag. If it's an normal adult patient, I'd give with no complications. I'd give 1 liter, then reassess. Are we doing better? Where are we at? Is there in urine coming? What? Then let's give the next, okay? If we are vasodilated, which is a clinical sign, then let's give some vasodilation. Is there a history of heart failure? Okay, so let's pump a bit in this. Yes. But so it's a titration, but key thing is do not give a lot of fluids. Yes, give fluids in steps, okay? And if your patient, for example, heart failure, elderly, whatever, 250 mLs, review. And the key thing you are looking at also, how to review your patient is, and to think about, have I given 2 fluids, is listen to your lungs.
Yeah.
Listen to your lung bases, okay? Can I hear any crackles, okay? If my patient's lungs were clear when we started, they should not change.
They should continue being clear.
Yes. So reassess your patient, listen to the lung bases, ensure that you're not going into fluid overload. Yes. Clinical assessment after every small amount of fluids that you give is key. Yes.
Okay. So bedside is king.
Yes.
But there are other things we can use. You mentioned the lactate, right? Tell me more.
Lactate.
No, I love a lactate.
We all love lactate, Lactate. So lactate, I mean, the cutoff is what, 2? Yes. So a higher lactate could be suggestive. Caveat of poor perfusion. And you have to go back to the physiology of where lactate is produced. Something about anaerobic metabolism, pyruvate, and all that. So there are other Krebs cycle. Yes, those who slept through the physiology. But the key thing is so poor perfusion means anaerobic metabolism means potentially increasing your lactate. Okay, but as I said, your lactate liver functionality could affect that and all that. So the key thing is, it's not very much about the number.
The first number.
Yes, it's where is it trending. Okay, if your number is trending upwards, there's a problem. Okay, so even if you start off with a lactate of 10, okay, for whatever reason. Well, again, it depends. Where is the lactate coming from? Yes, okay. So where is the lactate coming from? Okay, so if your lactate is, and you do a bit of resuscitation, it's coming back to 8. You're doing well. So the key thing is, are we dropping the lactate? Yes. But if your lactate was 10 and then next thing your lactate is 12, you are losing this. You're losing this battle. You're not doing enough. Okay. So that's the fancy one of lactate. Your pHs, okay, your acidosis, metabolic acidosis. Remember, your tissues depend on anaerobic metabolism. And start consuming bicarb, and your bicarb starts coming down, and your pH starts dropping. So is your pH dropping? Okay. So are you getting more acidotic? And this metabolic acidosis, then and please, just to highlight, okay, if your body is acidotic, the treatment is not bicarbonate.
Bicarbonate infusion.
Yes. No. Okay. The patient is acidotic because they are not perfusing. They do not have a bicarbonate loss problem. We are not trying to fix that. Okay. So your response to pH is, especially acidosis, is, why am I not perfusing my cells? Why are my cells getting acidotic? How do I fix that? Bicarbonate is not the treatment. Fix the problem, okay? And that will correct your acidosis. So blood gas, and you don't need a venous blood gas is good enough. You never need arterial blood gas. If you have a blood gas, I think all it is should have a blood gas machine. Yes, I think it's key. It'll help. But even where you don't have such fancy tools, a urine catheter, a stethoscope, and your clinical acumen will really keep your patient alive.
Okay.
Yes.
That's true. But in this day and age,
in this day and age.
Let's talk ultrasound.
Yes.
Tell me about
Now,
point of care ultrasound.
Ultrasound is a good tool to identify factors contributing to your shock.
Okay, yeah.
Okay?
Yeah.
So it will tell you if you're losing volume in the abdomen. Okay, so where you're bleeding internally,
Yeah.
ultrasound will tell you that.
Yeah.
It will tell you if you are losing volume in the chest,
Yeah.
okay, or if you have an pneumothorax that is really blocking.
Yeah.
So it will tell you that. It will tell you if you have heart, if you have blood tamponade.
Yeah.
So blood fluid.
Constricting. Yeah.
You have fluid around the
constricting.
heart
Yeah.
that is making your heart not beat enough. Ultrasound will tell you that. Okay. It will also tell you if your blood vessels from your heart to your lungs are blocked,
Yeah.
because then your right ventricle will massively dilate, the D sign and all that. So that will tell you, the ultrasound will tell you that. Now, issues of intravenous IVC, they're looking at IVC.
Reassessment.
Many factors could be affecting that, okay? But if your IVC is flat, okay, if your heart, your vessel, your inferior vena cava is flat, then you probably have a volume problem, okay? So that, but a normal IVC may not necessarily mean you're well perfused.
That's fair.
Yes,
Also,
okay.
in terms of like the context, in terms of also reassessment, do your first one, see where you're starting from. If you need to give your fluid, check again. Is it better, not?
See, again,
Yeah.
it's if it's flat, it's fine. That tells you probably have a volume problem, okay?
Yeah.
Anything apart from that is
neither here nor
contextual. Yes, you have to take it in the context in which you're assessing your patient, yes. But also the other thing I also like looking at is just looking at your heart. Is the left ventricle even filling with blood? You know, is it, and how is your heart beating? You know, if your heart is doing this, clearly you have a heart problem. Yes, so that's a good part of ultrasound. So it helps you pick up what may be contributing to your shock. It will not help you diagnose shock. It will not diagnose shock as a condition. It will help you identify the contributing factors to your patient's poor perfusion.
Okay.
Yes.
That's good. I like that. And I like ultrasound.
We all love our tools, yes. Tools and gadgets.
So now also in terms of reassessment, if you reassess your patient and you're seeing they're not getting better, the lactate is still going up, the blood pressure is dropping even further, they're more obtunded, how do you address that kind of situation? When do you decide, maybe I need to change something?
It's at that point, yes. The key thing is, what are you changing? Okay, so if you're not getting better, you've maybe started some fluids. Let's start with just basic response. You've given some fluids, okay? And your patient, you've reassessed the patient after, let's say, your first bag, and they don't seem to be going anywhere. So the question is then, have I given enough fluids? Okay, so it's either have you given enough fluids, or are the fluids getting lost? Okay, you're leaking from sepsis, for example. So your knee-jerk reaction should not always be, let's give another bag and let's give another bag. No. All right. So you should be factoring in, okay, I've given the first liter of fluid. How's my heart rate doing? How's my heart doing? How are we perfusing now at this point? Am I vasodilated, vasoconstricted clinically? What should I, if I'm vasodilated, for example, then my question would be, can I start some vasopressor support, for example? And then I'd then factor in, okay, so I gave some fluids and my patient has deteriorated, okay? That normally should not be happening. So then there's a problem somewhere. So, and then maybe volume may not have been the issue, that then we'd look to factor in vasopressors, inotropes. So it's at this point, it's you're either thinking, I need to constrict my vessels, or I need to support my pumping of, and again, look at your heart rate also. Remember, if your heart is going too fast, then that reduces the amount of volume coming in, which reduces your stroke volume. So you could easily be operating on I know the words have changed now. Atrial tachycardia. Is it? Yes. No. The terms for ventricular tachycardia, narrow complex tachy.
Yes.
You could be operating on a narrow complex tachycardia system where you're no longer going through the AC node and all that. So, am I having a rate problem? Is my heart rate too fast? Okay, and why is it too fast? Okay, is it a heart problem?
Yeah.
Or is it and an ECG will help in kind of differentiate some of this. So yeah, so then I'd probably then, if I'm vasoconstricted, poorly perfused, and my heart seems to be beating well, then I'll probably give another bolus and reassess. And then I'm not bleeding from anywhere. I'm checking. So that's the other thing about if your patient shows up bleeding, please stop the bleeding. Remember our pump analogy? Okay.
Yeah.
If you ever walk into your house and you find your tap is open and it's leaking, it's just pouring.
Yeah.
Your normal is close the tap.
Yep.
It's the same with the human body. Yes. If your blood is leaky, is pouring out, please go close the tap. Because no amount of water on this other side, and that's the thing. So for example, you have a patient come in and they are having, let's say, a ruptured ectopic pregnancy. Okay. Resuscitation is a priority, yes, but stopping the bleeding is a bigger. So there's no use of starting 10 liters of blood on this side and the patient essentially just getting in and getting out. Yes. So in such a situation, the priority would be, how do we quickly, put the bloods up, but we are in theater to stop. You have to close the tap. Yes. Because unless you close the tap, then you just keep leaking. Yes.
Okay. So basically management is resuscitate and then treat the cause.
You see, in an ectopic pregnancy, you may want to treat the cause because your resuscitation efforts may not work. Okay. Because all the blood you're giving is just ending up in the abdomen. Yeah. So you want to initiate resuscitation. Yes. So you want to initiate resuscitation, but you really want to plug there. In a trauma patient who's bleeding, for example, where it's exsanguinating, the priority would be to stop the bleeding. Yes. Close your pelvis, for example, in a pelvic trauma. Yeah. So the priority is initiate some resuscitation, but please treat the cause. Yes.
Yeah, and do not delay.
Yes.
Okay. So what's the single biggest mistake clinicians make when managing shock?
I think it's thinking, they are still talking to me. They are still
that false reassurance.
So BP of 50, 60 and the patient is still fine. I mean, that is the biggest thing where your patient is poorly perfused, but because they're still maintaining some mentation and getting it, they're like, we are good. Yes. And also ignoring the signs. Yes. Your patient has come in, they've been running a tachy of 120 the whole day. And you've just been seeing it and saying, I don't know, they're anxious or whatever. Yes. The signs are always there. Yes. I've reviewed a couple of cases and you could tell this patient was deteriorating and we were looking at it. But because they seemed fine. They had a BP of 120. That one is written very well. BP 120/70, heart rate 145. Next one, BP 120/70, heart rate 155. So everyone is more focused on the BP and less on the heart rate and less on the clinical, because at that point we're in clinical signs. So I think we ignore bedside signs and are quick to look at monitors, do blood tests, and ignore just looking at the patient. Yep. So most patients who've died from sepsis and shock, it's purely because no one was looking at the patient. Everyone was looking at the monitors and the labs and less at the patient. Yeah.
Or over reliance on one vital sign and not look at the full picture. Okay. So then, how do we guard against this anchoring bias? That
shock is an emergency. Okay. Especially from any clinical perspective, back to our ABCs. The only way you'll be alive is if you're getting oxygen into your system and blood is flowing. Basics, back to basic physiology. if your patient is oxygenating well and your patient is perfusing well, then they'll probably stay alive. Okay. If your patient is not getting enough oxygen for whatever reason, okay, the SATs are below 94%, and that's a problem. Okay. So, and if your patient is not perfusing well, okay, where you clinically can pick up that they have poor perfusion, that's a problem. Okay, so those are the key things in any patient. Everything else can be dealt with later. And that's why in always ABC, A means A is a means to B. Yes, because the only reason why we need your airway to be open is because you need to oxygenate. Yes. Okay. So A is a means to B. So oxygen, and then are you perfusing well? Yes. And clinical evaluation of your patient. We use there's a mnemonic we use RACEs. So what's your rate, heart rate? What's your level of consciousness, AVPU? What's your color? Okay, so are you grayish? Are you losing pale and all that? Have you bled out? Yes. ECG, I think we don't do enough ECGs. All these patients should have an ECG done. Anyone who is polyperfusion must get an ECG done, because you could easily pick up a cardiac cause of them being poorly perfused. So all patients with poor perfusion must get an ECG done. And then, as you can see, the BP, systolic blood pressure, comes in down the line. So we look at systolic because that's what pushes the blood forward. But again, I prefer we look at your MAPs, your mean arterial pressure, which is essentially your baseline pressure across the system. But those numbers mean nothing. Clinical is the most important part of it.
Okay. How often do you encounter cases of what I would call confirmation bias, where you're waiting for labs to tell you? Oh, yeah.
Every time. Because with modern medicine and all this gadgetry, and people have moved away from the traditional path of medicine, and we rely on labs to tell you, I'm waiting for the lactate to tell me if my patient is in shock. But your patient is in front of you. You can clinically tell they're in shock. Yes. So, and essentially when you boil down to the basics, you don't need always hear, I'm doing a gas to check my oxygenation level. If your pulse oximeter is showing you good saturation, and you have a nice waveform pulse oximetry. I
feel attacked because I've said that to you before.
Then when we do a blood gas confirm oxygenation, we can see it. And you can see the patient has a nice pulse form. So that means they're perfusing their finger. And there's very little reason why they should be inaccurate. But we want a gas to tell us the oxygenation level, but we can see it. Or we want a gas to see, to see the lactate. I'm like, but Sasa, now your patient is confused, cold, clammy, cup refill of 5, they're tachypnic. So that gas will tell you what? I mean, it just shows you how bad the situation is, but clinically the situation is bad. Yes. So I think the over-reliance on our gadgetry and our investigations, we miss and we lose out on the basic clinical signs that we should be looking out for patients. Even tachypnea, for example, when was the last time you just monitored the patient's breath? How fast are they breathing? Okay, they're breathing fast because they're acidotic. They need to get rid of some acidosis, and they're acidotic because there's poor perfusion. They need more oxygen. Breathing is another discussion. Yes, not today. So today we're discussing tachy. So two things: why is your patient hyperventilating? Why is your patient's heart rate going up?
And I think that's good news for the people who call themselves low resource settings.
I
don't like saying it because there's over reliance on that phrase. It's an excuse. It's a crutch now. We need to stop. But I was saying, it's good news for low resource settings because clinical acumen is king. You can really manage your patient from start to finish.
But even in high resource settings, imagine it doesn't matter what.
It doesn't matter where you are.
This is not a resource issue.
It's not. Exactly.
Because in fact, this is my biggest issue, especially when I look at cases even beyond certain species, is our patients don't die because someone did not do a heart transplant combination of our patients are dying from basics. They just were not given enough fluids. Okay, someone did not pick up, they were bleeding. Someone did not give them oxygen. Patients are dying because of antibiotics in sepsis. This is, I mean, simple. We're losing a lot of patients from very simple conditions, even in high resource settings, where we trivialize basic clinical signs, and the next thing, the patient is dead. Yet all they did was a bit of fluid, some inotropic support. Yes, and just on the vasopressors, it's okay to give diluted adrenaline and norepinephrine via peripheral line.
Yes.
It is okay.
Yes.
Yes. Not for a prolonged period of time. When I say prolonged, I say 6 hours, 4 hours.
Yeah.
But in the initial part, in the emergency department, dilute your adrenaline into some fluids and give that through a peripheral line. You do not need a central line to initiate inotropic or vasopressor. Keyword is initiate. Yes. You do need a central line to maintain vasopressor or inotropic support, but not to initiate it.
Okay. Thank you. So as we get towards a close, let's highlight evolving practice, right? Number one is heavy on the fluid, right?
Less on the fluid.
I mean, emphasis, heavy emphasis.
Heavy on managed fluid administration.
Yes. Exactly. That's what I'm going for. Because I think even in terms of, even our algorithms, right, on the Casualty app, suggested is 30 mils per kg, right? But that doesn't supersede clinical judgment in your patient on the ground.
Yes. Right? And doesn't say, hey, you need to give all of it at once. Let us give it all. We'll look at this later. No, it means that's more of where you are going towards, but it's not a target. Yes.
Yeah. Okay. All right. I like that clarification. Because fluid overload syndrome is a rapidly evolving.
Listen to your lungs. In kids, also look at their livers. I remember something, and spleens. Yes. I haven't seen kids for a while. Yes.
Okay. Another thing is personalizing your resuscitative efforts to your patient.
Yes.
Right. And understanding that, yes, a BP of 110 systolic in gene might be normal, but it might not be normal in person.
Yes, there's nothing like a normal BP. Yes. So normally you hear patient had a normal BP. I'm like, Yes. My more question is, was the patient perfusing normally?
Yeah.
So let's move away from normal BP to patient had normal adequate perfusion.
Yeah.
I think, yes.
Yeah, and then qualify that.
Yes.
Okay. All right. And then, do you think we underuse vasopressors or overuse them?
Underuse them. Yes. So someone will be giving fluids for the next 5 hours here, whereas, remember, a low BP, I don't know how best to explain this in terms of, like, it's like running, which analogy would I use? Yes. The light in your car, I don't know if it actually works, but the fuel light has come on. And then you keep driving expecting, I don't know which miracles. At some point, yes.
To generate some fuel somewhere.
Yes. Okay. So when a patient comes in with poor perfusion, it's like the fuel light has come on. Yes. Okay. They will stop at some point. Yes. So unless you fix it and get rid of that fuel light, it's not just going to magically, disappear. So we need to be able to quickly address the shock and the poor perfusion in this patient as soon as possible. And that sometimes means I start some fluids, but your fluids can only run at a certain rate. Yes. And then I start some inotropes on another line so that, or some vasopressors. So the two are quickly getting me where I need to go. And then at some point I may need to stop one and start the other, or just titrate both. But the key thing is, can I get back to perfusing the patient?
Okay. That's important. So as we wrap up.
Well, actually, maybe that thing I'd say is, managing shock is not orders.
Yeah.
Okay? It's not a chem. I said, give this, give this, give this. I will come to review. No. Managing shock is CPR. Okay? You stay there with the patient and fix the problem. Once they're perfusing well, then you can give orders. But until then, they are an emergency and need to be resuscitated actively. Yes.
And also, continuously asking yourself, why is my patient in this state is so important.
treat the cause,
Yeah.
and treat the cause soon. Sepsis will kill you faster than you can say sepsis. Yes, give antibiotics early. Start your steroids if you're going into inotropic support. It's just in sepsis. If you're bleeding, please let's stop bleeding. Okay, let's go to theater. Yes, you cannot maintain a bleeding patient on water. Yes.
Okay. All right. As we wrap up, what's one bedside pearl that in your practice you rely on always, that is always helping you save patients in shock?
Say hi to your patient.
Okay.
Okay. And I was told we used to be told this, I don't know, it's shock, okay?
Oh, and then you feel...
So, not necessarily. But just saying hi to your patient, number one, I can tell your level of consciousness from this conversation. I've already felt your hand now, okay? You're probably a bit hypoperfused, but that's a different discussion. But in the same breath, you can actually just quickly feel their pulse and see how that's going. It's a simple thing, okay? That will give you an idea of where we are starting from. Yes. Yes, just start saying hi to your patients. Yes, not treating them as numbers on a screen. Your BP is this, let's start fluids. Yes.
Okay. And if every healthcare worker watching this episode remember just one thing about shock, what would that be?
It kills.
Okay. So imagine saying it kills.
Shock kills. Shock kills more patients than we actually want to admit. Many patients die of shock. And yet it can easily be treated. All you need is water, some few drugs, which everyone has. It's not a resource issue. Everyone has this. Even the smallest facilities, they have the basics to manage shock. Yes.
Okay. Thank you so much.
Thank you very much.
That was a very nice in-depth discussion about shock.
Yes.
And I hope it changes the practice on the ground.
Yes, it should. And yes, let's hunt down shock and fix it.
Okay, great.
Thanks.
Now that we're coming towards the end of the episode, you know what comes next. Here are 5 things before you go. So first things first, shock is not hypotension. Hypoperfusion already occurs in the background long before your blood pressure drops. If you're waiting for your patient's blood pressure to fall for you to act, you're gonna be too late. So look for the early clues, the tachycardia, the tachypnea, and act immediately. Number 2, think about what's going on with your patient's physiology. Ask yourself, is the tank empty, hypovolemic? Is the pump failing, cardiogenic? Is the system blocked, obstructive, or are the pipes too big, distributive? Once you start to think about what's actually going on in your patient, you'll be able to pick the appropriate interventions early enough and save your patient's life instead of blindly throwing fluids at a patient who might not need it. Number 3, start resuscitation immediately. Your patient is in shock. They could die. It's an emergency. You need to actively resuscitate them presently. Be there at the bedside with this patient until they improve. The principles of ABCD still apply. And as you're resuscitating, you're simultaneously asking yourself, what is going on with the patient? What is causing the shock? What is the type of shock? And how do I address it? Number 4, treat the cause, not just the numbers. When you're actively resuscitating a patient and you're not seeing improvement, say what commonly happens. Low BPs, we throw fluids at them. After you've thrown the fluids, there's no improvement. The answer is not to keep throwing fluids at your patient. The answer is to find out what is the cause and change your intervention. You might end up finding, oh, this patient has anaphylaxis, I need to give adrenaline. This patient has sepsis, I need to give antibiotics. This patient has a PE, I need to thrombolyze. So treat the cause, not just the numbers. Don't blindly throw fluids at a patient. Don't blindly do any intervention. Try and figure out what is happening with the patient. Why are they this sick? Number 5, reassess. We always say this, reassess, reassess, reassess. Especially in this shock patients, the state is always very dynamic. Shock is a very dynamic state and there's a continuum. So you want to make sure after every intervention you've given, you reassess the patient. Is their mental status improving? Is their tachycardia reducing? Are their BPs improving? Is their urine output improving? Is the lactate going up or down? After every intervention, you must reassess. If they're getting better, you're doing something right. If they're getting worse, you need to change your approach. Always, always reassess.